презентации подготовлены на русском языке. Вот, это, конечно,
нарушение наших правил.
Да, связано это с тем, что мы принимаем участие в том или ином составе в вашей зимней школе не первый год и, честно говоря, просто не перечитали новые требования. По поводу этого доклада, он готовился также на русском, но если часть ваших слушателей англоязычная, я могу попробовать его перевести. Это нужно или продолжить на русском?
Ну, я думаю, что сейчас I drop a glance. English better. 1, 2, 3.
Okay. Можно выключить свет, пожалуйста? Well, this speech is about the tuberculosis in patients with AIDS. It's a part of my clinical medical PhD work, and now I want to present our data. First, a few words about the HIV in Russia. The portion of the patients with AIDS every year increases by 10%. That means that after the 7 years, the number of patients with AIDS in Russia doubles. So now we have one big hospital that works with patients with AIDS. That is 600 bed hospital, and it's full of patients. In the next 7 years, the second hospital would be full of patients if it were built, but it's not going to be built. And these data are the worst among the world. This number is the same as in the worst countries in Africa for now. Another bad sign is the percent of anti-HIV medication coverage. That is about 21%. In Africa, the number of anti-HIV medication coverage is 40%. It's twice as higher as what we have in Russia. That seems really dramatic for me. Well, few words about the tuberculosis in association with HIV. Being HIV positive is the strongest factor of getting tuberculosis. Well, being in jail, living with someone who have tuberculosis, working with patients with tuberculosis are well-known and strong factors, but they are much lower as opposed to being HIV positive. And even after 1 year after being HIV infected, any doctor would say that you are generally healthy being HIV infected for 1 year. But at the end of the year, the relative risk of getting tuberculosis will double. And that's gonna rise while the titer of CD4 cells going down. The HIV is a virus that attacks CD4 cells. What is CD4? CD4 is a protein on the surface of a specific portion of the cells that are the strongest actor of human immune system, and HIV attacks them. As the titer of CD4 cells going down, the risk of getting tuberculosis rises. And tuberculosis can grow in lungs, in human lungs, or that can grow outside the lungs. That could be disseminated. And the portion of disseminated tuberculosis is 22%, with 1 and 3% of all tuberculosis patients that have neurotuberculosis. So neurotuberculosis is something that is a really rare condition. But HIV increases the portion of extra lung involvement of tuberculosis, and the portion of neuroinfection also rises. Well, we found 46 patients with CD4 cells less than 100. The AIDS is CD4 less than 200. And most parts of the scanned patient had CD4 level less than 50. So they're really immunodepressed. And they had signs of focal neurological deficits, or long-time headache, or fever, or any changes in the spinal fluid. These were the indication for the brain MRI. And several forms of, in fact, tuberculosis in AIDS is something what is really rare, and that is not that much of publication about the forms of lung tuberculosis, of central nervous system tuberculosis. Few forms are really well known around the world, but several are rarely described, or just in a few articles, or something that they have found was not really well described in any of the papers I have met. And but this one is really common. This is the tuberculoma, brain tuberculoma, that is histologically that is the same that is going on in the lungs with tuberculosis. And this is the focus, surrounded by the edema, and the amount of the edema is out of proportion of the size of the focus. That is the characteristic of the tuberculoma. In case of contrast enhancement, that weakly enhances weakly, but if you double the dose of the contrast, or if you increase the post-injection, the time between the contrast injection and the scanning, the intensity of the focus periphery will rise. For that patient, we did not perform the late enhancement. It was in the beginning of our scanning history. Well, and that is the same patient in 2 months after the anti-tuberculosis therapy, 1 month and a half of, we did not perform the biopsy for this patient. What was performed is a test therapy confirmation. That means if you give 5 anti-tuberculosis drugs and the patient is getting better, that was tuberculosis, and the treatment has helped. And that is what happened in this case. You can see the size of the focus. It is getting smaller, and the amount of the edema is also going down. Well, next, the size of the intracranial granuloma can rise, can differ, but usually that's less than 10 millimeters. But what we have found in the next patient is something interesting, because now the focus was detected in the basal ganglia on the left side, and honestly I thought that could be the lymphoma, lymphoproliferative disease or something like that, but after the contrast enhancement it was determined that it is round, it is actively enhancement, and in fact there are 2 focuses that you can see here, and the DVI is present here. That is present here to explain why we did not state the abscess here. The abscess usually gives high intensity signal from the center of the focus, but no signal increased from the center of the focus was determined here. Well, and the late scanning after the enhancement was performed here, and now you can see that the size of the border of this focus has changed and increased. That is, the late enhancement is not really well described in the papers. I don't know why. Maybe because that's time-consuming, and but in our opinion, that's a really good and informative tool that is close in sensitivity as a double contrast enhancement, but it's just much cheaper. Well, next representation is a spinal tuberculoma. Usually, that's a rare presentation, and that happens much more rare than intracranial tuberculosis. So just to show you something that is rare. But histologically and from the point of MRI imaging, it is the same. Well, this form was described in Indian article, but it was not described in United States, from article from the United States. That is the, I think that is because the prevalence of both HIV and tuberculosis in India is much closer to Russian Federation as opposed to the United States. But here you can see the asymmetry of the blood flow of left and right sides in the middle meningeal artery. And after the contrast enhancement, you can see the para-arterial contrast enhancement. This and this. This is the branch of the middle cerebral artery. Well, this form, I didn't find the good description for this form. It is the same patient that had the vasculitis, but now please take a look at this region. This region, you can see a number of small round foci that are rarely grouped, rarely closed. This group is distributed in the branches of the meningeal of the artery with vasculitis, and I think that this area. But in this case, the such changes in the vasculature was not determined, and this patient had an autopsy. And please take a look at this region. Here you can see small vesicles. This region is exactly the same that is shown here. Well, and the question is how to describe that form, because of the pathologist during the autopsy said that he thinks that is the meningeal spread. But here you can see the cortex, and these tuberculomas, they involve cortex. So it is between the meningium and the cortex, and it is not yet clear where is the origin of this granuloma comes from. The glasses, you know, the small cuts of this piece of brain is at work. That takes about several months for the workup with the glasses. So the work is on the go about this patient. Well, a few words about the meningitis. US article says that the most common form of tuberculosis brain infection is a meningitis, and meningitis divides into pachymeningitis and leptomeningitis, and pachymeningitis is not that typical for tuberculosis, the article says, but we found several patients with dura enhancement, and here you can see the effusion, subdural effusion, but this is how a leptomeningitis looks like. And the article says that the frequency of leptomeningitis is 60 to 80% from all the tuberculosis brain changes. But we have not seen any patient with this form of tuberculosis. I think there could be two answers for the question why didn't we find any cases with such a form. The first one is that our patient is severely immunodepressed. The CD4 level less than 50 is a severe AIDS. But another possible opportunity for this situation is the BCG vaccination that is common in Soviet Union and all the countries post-Soviet Union. And several articles says that BCG protects children until the age of 18 from the tuberculosis meningitis, and it might change the representation of the meningitis in adults, in my opinion. That is something that should be yet evaluated. Well, that is the video. Can you please start the video for me? The patient came with the complaints for the headache. Okay, thank you. Can we switch to the presentation again, please? Okay. Should I switch? Oh, okay. Is that you are switching? Okay.
Not more than a couple of minutes.
Okay, that's just a few slides. Okay, okay, thank you. Now, just some details about this patient. Here you can see the mass behind the dura. It is between the bone and the dura. Why do I know that is behind the dura? Because that is the sinus. Sinus is that comes from the dura, and that is pushed forward from the bone. And here, this piece is out of skull. And after the contrast enhancement, you can see peripheral enhancement of this lesion with on the sagittal plane. You can see that it spreads from intracranial area, this is the cranium, to area outside of the cranium. So this abscess made a hole in the skull and spread it from one person to another. I'm not yet sure is that coming from the soft tissue to the bone, or from to the cranium, or from the cranium into the soft tissue, but it is not that important. But this form has not have not been found in papers. And just to show you how tuberculosis abscesses get the increased signal at diffusion weighted images, just to compare with the big tuberculoma that is more than 10 millimeters in diameter. Well, thank you for the attention.
Your questions? It can be in English and Russian, please.
Some slides have movement. I observed that some of your slides have a movement phantasma. The patient is moving inside the MRI.
Yeah.
And you did you consider the possibility to have 3D reconstruction of the tuberculosis? Because sometimes you see one slide have an area, but during the time it's changing the position of the patient. Yes.
Well, they're performing some 3D sequences, but usually they're more sensitive for the patient movements. So, in fact, it is not that effective to run the 3D sequences.
Sorry. I mean, no 3D sequence.
Okay.
I mean, make a 3D reconstruction from the 2D slide. A lot of 2D slide, and by software make the 3D reconstruction.
Well, we prefer to run in MRI in different planes, so axial, sagittal, and coronal, and not to perform the reconstruction from the axial plane to the sagittal, something like that, due to the slide shift. So we don't use that tool at all. We never reconstruct sagittals and coronals at all.
How many slides you have?
Every sequence, about 25 sequences for
25 slides.
25 sizes in three planes.
Axial, for example, no?
Yeah, for example.
It's enough.
Yes, but it's difficult to reconstruct. Then you have a shift. Then you don't have a shift. That's a possible tool. But while having a shift, then in this slice you can see the foci. On the next slice, it is out of this the line of reconstruction. So we don't use it.
You're using a special program.
Yeah.
But we don't find that informative. That is possible, but not useful.
Any questions? No? Thank you. Again.
Thank you.